Thank you very much for giving me the opportunity to give this talk about PPROM. So there are really different practices around the world in case of PPROM. And in some country, people induce labor after antenatal corticosteroid from 28 weeks gestation. In others, people induce labor at 34 or 37 weeks gestation. And tocolysis is authorized or forbidden according to centers and countries. So if we go back to the physiology of PPROM, the leading hypothesis now is that there is inflammation. It is not really known. It's from bacterial origin of primitive inflammation. Anyway, there is inflammation leading to, in some cases, colonization of the amniotic cavity by bacterial like Mycoplasma or others, and finally leading to PPROM. And the problem is what to do in case of PPROM: immediate delivery that increase the risk of prematurity, or waiting with an expectant management that improves gestational age but exposed to the risk of clinical chorioamnionitis, placental abruption, or cord prolapse. And what is really central into the reflection about this is the impact of chorioamnionitis on neonatal outcomes. Because what we know is that in case of PPROM, the risk is an inflammation, local inflammation, leading to fetal inflammatory, cerebral palsy, early onset neonatal infection, and even death. And the first step, even before thinking about tocolysis, is when to deliver in case of PPROM. And if we try to answer to these questions through a randomized study, what we can observe is that they're mainly performed after 33 weeks gestation. You have here all the randomized studies that have been performed in case of PPROM. And this one, the last one, Promexil and Promte, are for 34, 37 weeks gestation. And if we try to look at before 34 weeks gestation, the studies that we have are old and with a low number of women included and do not allow to answer to this question. And therefore, what we have left to try to answer the question before 34 weeks gestation, what to do, is observational studies. And with two questions: what are the clinical consequences of subclinical infections? That means, what are the clinical consequences of silent inflammation and consequently histological chorioamnionitis? And the second question is, what is the impact on the neonate of the latency duration? That means if a baby is born at 33 weeks gestation, his prognostic is the same. Does his prognostic is the same if the PPROM occurred 2 days ago or 3 weeks ago? And this is what we tried to answer to a very big cohort in France that named is EpiPage 2, and that was performed in 2011. And we tried to answer to these two questions: chorioamnionitis, long latency duration. Does that really matter? Regarding chorioamnionitis, there are 3 meta-analyses that has been performed since 20 years, and the results are, for clinical chorioamnionitis, probably an association with cerebral palsy. For histological chorioamnionitis, there are discordant results, and we actually do not really know what is the impact of histological chorioamnionitis on neonatal and child outcomes. But all of this study nearly included also preterm birth with vascular disease like preeclampsia, IUGR, and in these cases you don't have chorioamnionitis, and it is not the correct group to make this kind of analysis. And actually the true question is, In cases of PPROM or preterm labor, does a histological chorioamnitis worsen neonatal outcomes? So we did that through the EPPH2 population-based study. That is a prospective national population-based cohort with recruitment from March to December 2011 on 25 regions for neonates born from 22 to 34 weeks gestation, and with prospective follow-up of maternal, obstetrical, and neonatal data, and a follow-up that is expected to be until 12 years old. And we studied specifically this question of clinical chorioamnitis and histological chorioamnitis. And what we showed is that in case of clinical chorioamnitis on this cohort, you have an increase of the risk of cerebral palsy. But in case of histological chorioamnitis, there is no difference regarding the risk of cerebral palsy at 2 years old for the babies. So it was really the first step and an important question for us that we had to answer. The second question was, what is the impact of the latency duration on the neonatal prognosis in cases of PPROM? That means, what is the main prognostic factors? Is it the gestational age of rupture of membrane, or is it the gestational age of delivery? And we performed this study too, still on the EPPH2 cohort, and included the 702 singleton infants alive at PPROM and delivered from 24 to 32 weeks gestation, and studied specifically the latency duration, meaning the time from PPROM to delivery, with two outcomes, survival and survival without morbidity. And what we showed is that finally, when you look at the latency period duration here and the probability of survival or survival without severe morbidity, there is no increased risk of death or morbidity when the latency period duration increase. It's not only that the confidence interval take one, but also that the risk that we have is slightly lower in case of increase of latency duration. And what matter actually is the gestational age at birth that increase the prognostic. And finally, what we can say is that for a given gestational age at birth, latency is not associated with survival without morbidity, but gestational age at delivery is. That means that what matters is the gestational age of delivery, and that that expectant management is the good option on this observational study. Of course, it's still not a randomized study. So finally, infant prognosis depends on gestational age of birth and not on the gestational age of PPROM, and the risk of death of cerebral palsy is not increased by histological chorioamnitis or longer latency duration. And what matters is the gestational age of birth, and you have here the results of the EPPH2 cohort that included, I remind this, neonates from 22 to 34 weeks gestation, and really an increase of even 1 week is associated with an improvement in survival. So what about tocolysis? Should we not only try an expectant management, but also give a tocolysis to women to try to increase gestational age of birth? What we can say, I hope that everybody can see, is that all the studies are really old, but a meta-analysis was published 3 years ago and shows that survival was not modified by tocolysis. Survival was not modified, but what was reported is that there was an increase in birth within 48 hours in the absence of tocolysis, so it works. It works, but with a potential increase in the risk of chorioamnionitis. So we don't have any impact on neonatal death. We have more chorioamnionitis and in case of tocolysis, but less women delivered in the 48 hours. So we don't really know what is the final impact on the prognosis, given the fact that the 48 hours are used to give corticosteroid to the woman that is associated with an improve in survival and a decrease in neonatal morbidity. The validity of the included study is quite low because they are small, old, 6 less than the 90s, without antibiotics in most cases, and also without corticosteroid during this period. And the external validity to our current practices is actually very low. So we decided to study this specific point and also the EpiPage 2 cohort, sorry for my French, to investigate whether tocolysis after PPROM is associated with improved neonatal and obstetrical outcomes. And we included for this study 803 women. And we excluded all contraindication to tocolysis. A time from PPROM diagnosis to delivery less than 2 hours because these women didn't have a PPROM but were already in labor. And finally, in our study population, we have nearly 600 women receiving tocolysis and 207 without tocolysis. So it's observational. So what we have to do from a statistical point of view is to try to make a propensity score. That is, we try to equalize the characteristic of movement in the two groups to make that comparable. And what we had is that tocolysis is not associated with survival without severe morbidity, not associated with an increased latency duration, and even not associated with a higher rate or lower rate of histological chorioamnionitis or phoenicitis. So no impact of chorioamnionitis. And we studied this also on the whole population without exclusion and a subgroup of women with a latency duration of more than 12 hours to see if there was any change in our results, but it was always the same. So finally, and in conclusion, tocolysis is not associated with improved neonatal outcomes or prolonged gestation. These results currently do not support tocolytic therapy for women with PPROM, but I would like to insist on the fact that it's really observational results. And therefore, there is a need for a large randomized controlled trial designed to study the impact of tocolysis on neonatal outcome. That is not always easy to perform because when you propose to a woman that have a rupture of membrane at 25 weeks gestation to not have tocolysis, it's sometimes quite difficult to accept. And this is what we are going to do in France. This trial that I'm conducting have received a grant, and we're beginning this study in next year. Thank you very much.